Good evening, everyone, respected faculty and dear delegates. I am here to present the poster on the topic Fibrothecoma of pregnancy and enigma. I would like to express my thanks to my ma'am, dear Pramila madam, Betsy ma'am and Anod sir for helping me and supporting me for this. The case spanned over about 8 years, and she was primary and she was referred to us on postnatal day 4 with bilateral adnexal masses, and the patient was a Muslim lady who was wearing a burqa and she had a face covered. So the obstetrician only noticed her facial hair growth when she was admitted in the labor room for delivery, and on examination they detected facial hair growth and bilateral adnexal masses, and the patient was referred on postnatal day 4, and on admission, on examination, she had increased terminal hair, then she had clitoromegaly and had hoarseness of voice, and on further evaluation, her serum testosterone levels were elevated to more than 2000, and she also had bilateral adnexal mass lesions. On the right side there was a lobulated mass of about 13 into 10 into 5 centimeter, and on left side the mass was about 5 into 4 into 3 centimeter, and it had multiple internal calcifications, and it was suspected a malignant lesion. But later, and it was suspected, and we clinically suspected a luteoma, and later after on follow-up, within a few weeks, her testosterone levels became normal, and so she was on close follow-up, but later there was an increase in the size of the mass, so we planned and we advised her for a biopsy and surgery. But after which she did not come for further follow-up and she was lost to follow-up. Then 8 years later she presented with a second pregnancy with a dating scan that showed bilateral adnexal lesions, which was 16 into 8 centimeters on the right side and 7 into 8 centimeters on the left side, which showed macrocalcifications, and this time her serum testosterone levels were within normal limits and all the tumor markers were also within normal limits. We did an ultrasound guided biopsy and the report came as fibroma or thecoma, and the IHC report came as negative for both calcitonin and inhibin. So after discussing in the multidisciplinary tumor board, we decided after that, and also she had an increase in the size of the tumor. By about 12 weeks, the size of the tumor almost doubled in size, and she also had severe abdominal pain. She had ascites, and as the size of the tumor increased, after discussing in the multidisciplinary tumor board, we went ahead with planning a staging laparotomy for the patient. And after counseling her regarding the chance of future infertility and regarding the chances of expulsion or miscarriage after the surgery, we proceeded with the surgery, and bilateral salpingo-ovariotomy was done for her. And later on the post-operative day 1, she expelled her products of conception, and the report of the histopathology came out as fibrothecoma, and it was positive strongly, which was a patchy positive for both inhibin and calcitonin, so it was diagnosed as fibrothecoma. So in this case, it was a challenge to diagnose as well as to treat, because for diagnosing, first of all, it was inconclusive. The HPR report was inconclusive, and the size of the tumor was increasing quickly. So we went ahead with staging laparotomy, and also. To conclude, I would like to say that diagnosing and treating ovarian tumors in pregnancy is a challenge, as it requires individualization and focus on both maternal and fetal outcomes. Thank you.